Good afternoon, and thank you for joining us for Astarte Medical's webinar presented by Dr. Michael Georgieff on nutrition of the preterm infant to promote brain health. I'm Tammy Jansen, co-founder and CFO of Astarte Medical. For those of you who don't know us, Astarte Medical is a precision nutrition company providing digital solutions to support nutrition and feeding practices for preterm infants in the NICU. We're hosting a series of educational webinars, all focused on the growth and development of preterm infants and the importance of feeding, nutrition, and gut health. I'm excited to share our incredible lineup of upcoming speakers with you. You can find the details for all of our webinars, both past and future, on our website. Please mark your calendars and join us for our next webinar on January 28th for a presentation by Dr. Sarah Taylor on promoting breastfeeding in the NICU and after discharge. Dr. Taylor is an associate professor of pediatrics at Yale School of Medicine. She's the director of Yale Neonatal Clinical Research and leads the Yale Neonatal Nourish team, which specializes in health outcomes related to maternal and infant nutrition. In addition to her NIH and foundation-funded research program, Dr. Taylor is an advocate for mother and infant nutrition at the international, national, and local levels. Watch for the invitation to Dr. Taylor's webinar in your inbox next week. I'm pleased to introduce our esteemed presenter and expert in the field of neonatal nutrition, Dr. Michael Georgieff. Dr. Georgieff is the Martin Lenz Harrison Land Grant Professor of Pediatrics at the University of Minnesota. He is Executive Vice Chair of Pediatrics and Director of the Center for Neurobehavioral Development at the university. He's an internationally recognized expert on the effects of nutrition on the developing brain, and specifically the effects of iron status on neural circuits involved in learning and memory processing. I also want to extend a huge congratulations to Dr. Georgieff on being awarded last week with the March of Dimes Agnes Higgins Award. The Agnes Higgins Award honors the late Agnes Higgins of the Montreal Diet Dispensary for her innovation and years of service to improve maternal nutrition by greatly advancing the understanding of eating healthy as a crucial factor in healthy pregnancy and the prevention of low birth weight babies. The Agnes Higgins Award is presented in recognition of distinguished achievement in research, education, or clinical services in the field of maternal fetal nutrition. So congratulations, Dr. Georgieff. We'll have plenty of time for Q&A at the end, so please feel free to post your questions throughout the presentation in the chat box on the right-hand side of your screen. We'll compile the questions and get to as many as we can at the end. I'll now turn it over to you, Dr. Georgieff.
Thank you, Tammy. Let me bring my slides up. While I'm bringing my slides up, let me say I have heard that talk by Sarah Taylor, and we had her for grand rounds here maybe about a month ago, and it is outstanding. So do not miss that. All right, I'm going to try and share my screen. Let's see what we have here. Okay, unless I hear otherwise, I'm assuming everybody sees this. Hello, everybody, and welcome to this seminar. So I've been asked to talk about nutrition of the preterm infant as it relates to brain health, and I just want to start by saying that if you have not read an article that was in the American Journal of Clinical Nutrition called the Pre-B Project, I'm sure many of you are familiar with this. You should read it, because I think what it tells you is, why do we care about nutrition in babies? And the answer is because of relevant health outcomes. How does nutrition of the preterm affect relevant health outcomes? And you can kind of list those out if you want. I would put neurodevelopment at the top, of course, but others would put bone health at the top, or cardiovascular health, or let's say immune health, or risk of cancer. Any of those would be relevant health outcomes, because after all, if what we did didn't matter in the long run, it's kind of no harm, no foul. So this talk is really to emphasize the importance of nutrition that we give babies on brain health. I don't have anything of interest to disclose, and I thought I would start by talking about nutrition in the brain in general, just some general principles, or what we would call rules of engagement, to get us started, so that we don't attribute magical effects of nutrition on the brain. We try and stay as evidence-based as we can, and to understand that the brain is really not a single organ. And So the effects of nutrition on the brain are going to depend a lot on these principles of timing and dose and duration of nutrient exposures. So I think we can all agree on this general principle that nutrients regulate brain development during pre and postnatal life. And we know that the first 1,000 days, and in the first 1,000 days, we're talking about from conception to about 2 years of life, postnatal life. And I've really come a long way here in terms of my thinking. I used to think when we got a preterm baby in the unit, you were kind of handed a blank slate and you were, kind of moving forward from ground zero. Well, it turns out, of course, that babies come with a history, a prenatal history, and that brain growth is pretty much a continuum from early post-conception through the second and then the third trimester, with a lot of growth in that third trimester. And birth is just kind of an event there. Now, when I talk to my moms in follow-up clinic, I always say, I know it's an exciting time for you, but your baby's brain really didn't care all that much when the birth event occurred. And of course, our job in the unit with the preterm babies is to try and continue the quantity and quality of that growth that would have taken place in that third trimester. That brain is very rapidly growing. And any organ that is rapidly growing has two properties to it. One, it's more vulnerable to damage. So if you are dependent on certain substrates, oxygen, glucose, protein, iron, so on, that support rapid growth, then losing those nutrients or one of those nutrients is going to cause more damage during a growth phase than during a static phase. The interesting thing is that baby brains, as you all probably have experienced, are remarkably amenable to repair. There's a great deal of plasticity, and insults that happen to baby brains, if they were to happen to you or to me as an adult, would cause significant long-term morbidity. And yet babies seem very capable of rewiring and adjusting their brains. So they're more amenable to repair. But I think everybody, and this was stated by the National Institutes of Health, back in the mid-90s, that vulnerability to damage outweighs the plasticity. So another way to say that in terms of nutrition is stay on your growth curve, don't fall off the growth curve, and then expect plasticity to make up the difference. So why is that brain so much at risk for these early life changes in nutritional status? Well, if you look at the caloric needs or the energy, the oxygen consumption, the energy demands of the preterm baby, they're very high compared to adults, right? So adults probably require about 45 calories per kilo per day. But babies, term babies would be around 100 calories per kilo per day, preterm babies up around 120 kcals per kilo per day. As you and I sit here and talk about this, about 20% of our 40 kcal per kilo is going to run our brain. Now that's a lot, right? Because basically your total body oxygen consumption is a sum of all of your organs put together. And the big one in your skull is taking 20% of it. So it's a big number. But in a newborn baby, that number is 60%. So 60% of the baby's total body oxygen consumption and therefore caloric demand is going to the brain. And what's it doing? We'll see in a second. So any nutrients or metabolic substrates that support oxygen consumption, support metabolism, are going to be highly in demand during this rapid growth phase. And then you can list them out. They would be oxygen, glucose, amino acids, certain fatty acids, iron, copper, and iodine. So what's the brain doing with all of these substrates? Well, it's taking us from, and these are pictures or cartoons of babies or fetuses from about 5 months post-conceptional age to 9 months. And you can see the brain changes dramatically as it goes from something that looks like a coffee bean at 5 months, just smooth and bilobed, to something that looks much more like an adult brain at 9 months. That's 9 months gestation, right? So that's a term brain right there. Of course, all that folding and all the gyri and sulci that you see there are ways of compacting a very large structure into a small space. You have to have all that folding. So that gives you an idea externally how much development is taking place in that last trimester. And of course, if we have babies that are born at the beginning of that trimester, it's a pretty awesome task for us to make sure that that occurs successfully. You can also look at this in a slightly different way, and that is to see how much of brain development across the lifespan, which is this is a map of, occurs in the first 3 years or the first 1,000 days, if you would like, however you want to define it. I put kind of a red box here around those first 3 years so that you can see all of the processes that are starting to take off and peak. So that's the height of the waves, peak in these time periods. You can see that a lot of the processes begin prior to term birth. So myelination starting at about 2 months before term birth. It starts in the brainstem, kind of moves its way forward. Synaptogenesis, so your brain hooking itself together, starts at about 28 weeks gestation, particularly in the hippocampus, which is the area that's involved in recognition memory. And even the frontal lobe, which is involved in much more complex behaviors like executive function and working memory and attention. Even that has a ramp up early around just prior to birth with a peak later. What I want to illustrate is that this is your golden opportunity. This with the area that's in the box here. This is your golden opportunity to do good by the brain. That is, this is the time that you want to be absolutely ensuring that you're providing the substrates such that these areas are developing normally and hooking up normally. If you try and do it later, so here I've just put in the dotted lines, or the dashed lines rather, to show you the amount of brain development that is taking place in middle childhood, you can see that still a lot is taking place, but there are certain processes that are already coming to an end. Their sensitive or critical windows are coming to an end. And if we extend it even further out into the tween and teenage years, you can see structurally the brain is pretty well put together by then. So it's going to be a lot harder to influence outcomes out here in the adolescent period than early on. So just think of this as a demonstration of your golden opportunity. If we then look at what's happening when we are concerned, which would be from conception onwards, and then certainly the time period from when they would be in the NICU and in the immediate post-discharge period, you can see we have an opportunity to influence hippocampal development, myelination, and synaptogenesis. And so there are nutrients that are involved in, that are specific for those processes to take place successfully. So you can already see one point that I'm trying to make here, which is that we talk about the brain like we talk about the heart, or we talk about the lungs, or whatever organ you'd like. But the brain is actually not a homogeneous organ. It's actually a bunch of little organs put together, defined by their regions, like the cortex, the hippocampus, the striatum, the cerebellum, and also processes that are taking place across these regions. Myelination and neurotransmitters that have a developmental time course. All of these regions and processes have different developmental trajectories, just like I was showing you on that previous slide, and therefore are going to be differentially vulnerable to nutrient deficits, right? So certain nutrients are necessary for, let's say, myelination or for neurotransmitters, and there are certain time periods when you're more likely to have a nutrient deficit. So the vulnerability of any of these regions or processes is going to be based on two things happening at the same time: when a nutrient deficit occurs, and that region or that process requires that nutrient at that time. If you have a nutrient deficit at a time when a particular region or process is not developing rapidly, you're not going to have a big impact. So those two things have to happen together. And if you want to look at a time in human life when that's most likely to happen, it's in that third trimester and then on through the first 2 years postnatally. So that's why it's defined as such a vulnerable organ. If you summarize that, you can do that, and these rather famous people in nutrition did back in 1996. They stated that any positive or negative nutrient effect on the brain is going to be based on two things. I know it looks like three, but there are two there. Timing, right? And that was based on what I said in the previous slide. And then the dose and duration of the exposure. And you can kind of think of that as an area under the curve. How big a deficit, or if you're thinking about overnutrition, how big a surplus, and for how long, and how is that affecting these various regions. So these nutrient effects can be regional or they can be global. It really depends on the nutrient and what systems are developing. So here's a list or a table rather of global or rather perinatal brain development. And you can see, for example, that protein energy has a deficit, or protein energy as a nutrient has a pretty profound effect on many aspects of neurodevelopment: cell proliferation, differentiation, synaptogenesis, and it really affects all areas of the brain. So you get a global effect there. Iron is a little bit more specific. It affects myelin, it affects dopamine, and it affects the energy metabolism of the cells. And so it's the areas that are being involved or that are growing at that time in the perinatal period that are going to be most affected. And you can kind of just go down through this table and see either specific or global effects. I mentioned before this kind of no harm, no foul kind of idea that if we have nutrient deficits, if a kid falls off a growth curve, but you could demonstrate that getting them back on the curve and everything goes back to normal and there's no long-term effect on a relevant health outcome, maybe we don't need to worry about this so much. And that's basically how nutritionists think about this. Altered nutrient status in fetal and neonatal life can affect organ, in this case we're talking about brain, structure and function. It can certainly affect it during the time of deficiency. So you get acute dysfunctions. For example, if you're acutely iron deficient, you will have mood issues, you will have memory problems, you will have slow processing. And by treating the iron deficiency, you hope that most of those will go away. Many nutrients, however, show effects beyond the time of deficiency, meaning that you treat the nutrient deficit and yet you are left with residual neurologic or neurodevelopmental issues, and that charts a course then for them of altered development. And in models we can see across the lifespan, and that's supported by epidemiologic studies in humans. And obviously the cost to society is from these long-term effects, because loss of neurodevelopmental potential usually equates with loss of educational potential and then loss of job potential. So just a couple of examples from humans, again, of how early life nutrition makes a difference long-term. So intrauterine growth restriction is associated with an increase in cardiovascular risk and also reduces your IQ by about 7 points. I like the one down on the bottom here, which says that eradicating the iron, zinc, and iodine deficiency around the world would increase the world's IQ by 10 points. So I could ask, I suppose through the chat or something, a show of hands of how many people would like an extra 10 points on IQ on any given day. It's a pretty profound effect that these combined nutrient deficiencies have. Now, all nutrients, so you go through your entire categories of all the nutrients out there, they're all important for development because they are all supporting cell metabolism and in this case, neuronal development. But some of them seem to have a particularly large effect in the perinatal period. And I've listed them out here. The superscripts tell you a little bit more information. For example, everything with a superscript of 1 has been shown to have a critical or sensitive period for neurodevelopment. That is, if you don't supply those nutrients in adequate amounts during a period of rapid regional brain growth, you're going to affect the neurodevelopment. All of those with the superscript 2, which is most of them with 1 that had the superscript of 1, are the ones that show that either through human studies or preclinical studies, or usually both, that an early deficiency results in long-term dysfunction. So that's the cost to society I was talking about. And now we're starting to see what some of the mechanisms are besides you just built it wrong. What some of the other mechanisms are that can account for these long-term dysfunctions in spite of treatment of the deficiency. And that is through epigenetic mechanisms, and you can see the ones that are superscripted 3. I'll have a list for you a little bit later on of all of the nutrients that have been shown to have epigenetic effects on the developing brain that are long-lasting. I kind of showed you on that map of brain development that there are certain systems that are developing in the time period that we would be taking care of the babies. So these early years, those first 1,000 days, or from fetal time period to 3 years, and particularly in the NICU, there are primary systems that are rapidly developing. I talked a little bit about the hippocampus before and myelination, and the other one is your neurotransmitter reward system. And that is the monoamine, so dopamine, serotonin, and norepinephrine. Each one of these starts ramping up in terms of activity during that third trimester. Hippocampus around 28 weeks, myelination around 32 weeks, dopamine probably around 24 weeks, and continue through that third trimester and on into the postnatal period. Hippocampus out to about 18 months, myelination out to about 2 years, although you're always kind of changing these and turning them over with time, but the rapid growth is during that time period. So nutrient deficiencies that affect the building of the myelin, the structural components of the hippocampus, the regulation of the monoamine neurotransmitters would be affected in that newborn period. But those systems need to be intact and working in order to build the later developing system. So remember I showed you that the frontal lobe develops quite a bit later, but it is dependent on the fidelity of your hippocampus and your striatum and the ability for the information to get from those areas to the frontal lobe. So it's not surprising, for example, in our preemies, when I see them in follow-up clinic, that they may have some learning and memory problems, but they also have frontal lobe problems, even though the frontal lobe probably wasn't directly hit by the nutrient deficiencies in the newborn period. So it's a scaffolding kind of effect, right? We think in terms of the brain constantly building itself and becoming more complex. There are really kind of two major theories that account for this long-term loss of neurodevelopmental potential, or what we call synaptic plasticity, the ability of the brain to perform at its peak ability. And one is a pretty simple hypothesis. It's just the residual structural deficits, and it's what I was talking about. Nutrient deficiencies that occur during critical periods of a region's development, okay? So the hippocampus developing rapidly during that third trimester or in the NICU, and then on into the postnatal period. If there are nutrients that are critical for the development of the hippocampus and they're not there, that hippocampus will remain structurally abnormal, at least as we see by our models, will remain structurally abnormal on into adulthood. And I'm showing you this down here on the bottom, where on the left-hand side, you can see a hippocampus of area CA1. This is where memory formation kind of takes place. And this is an iron-sufficient hippocampus in an adult animal. This is a mouse. And you can see how just beautiful it is. I mean, these cell bodies are nice and lined up nicely. The dendrites that are hanging down are all organized, makes for an easy target for information coming in. On the right-hand side, we see an iron deficient hippocampus. This animal actually was iron deficient as a baby, as a fetus and a newborn. And these are the residual structural deficits in the adult. And you can see that the cells are disorganized, that the dendritic structural pattern is really quite different than in the iron sufficient. So this is the residual structural deficits hypothesis. And then I'd mentioned before that there's more and more information that, just like with cardiovascular and liver metabolism and so on, brain metabolism is also, and regulation of brain synaptic plasticity is being set in late fetal and later and early postnatal life. So I think most of you are probably aware of the Barker hypothesis and the whole idea of developmental origins that, for example, intrauterine growth restriction increases the risk of cardiovascular disease because of the way certain enzyme systems that are set early in life then persist throughout the lifespan. And the way that happens in part is through epigenetic modification. Well, the same thing happens in the brain, and this is a list of nutrients in which fetal and neonatal nutritional conditions are associated with brain epigenetic modifications. And these modifications can be global, or they can be very specific for things like brain-derived neurotrophic factor, which is a major growth factor in the brain. So for example, iron deficiency suppresses the synthesis of brain-derived neurotrophic factor and results in less brain growth. You give the iron back and you come back and measure the brain-derived neurotrophic factor as an adult, and it's still low, right? And we now understand that that is because of an iron-dependent effect on histones, one of the ways that we have epigenetic marking. So again, it's not necessarily to remember all of this, but to demonstrate that certain nutrients do create epigenetic alterations in the brain for critical synaptic plasticity genes, and these epigenetic marks last into adulthood. And then there are others that for which there is no current evidence, either because nobody's looked or because they just don't occur. So let's break down that list of the nutrients that are particularly important and go through what they are doing in the brain and what that means in terms of our nutrient delivery to preterm babies. And let's start with the macronutrients first. So the macronutrients obviously have a major role in the brain. The brain basically runs on glucose, although it's pretty good at using alternative substrates. That's not the preferred way to do it. So if you have a brain that is utilizing 60% of the total body oxygen consumption, you can imagine that the glucose need is quite high, and it needs to be maintained. There are other carbohydrates that are involved in neurodevelopment, and those are the oligosaccharides. Their role is still being actively defined, and so we really don't have recommendations yet in terms of what is necessary. We looked at how that brain went from that 5-month coffee bean to that 9-month walnut-looking structure, and you have to realize that that is all structural development, and structural development is highly dependent on protein and on amino acids. And so, our current recommendations from protein are much, much higher than they were when I first started in this field. Actually, when I first started in this field, we didn't give protein to babies. At least not in the beginning. And then we started at maybe 1 or 1.5 grams per kilo per day, and we timidly moved up and worked from the Colorado group, Patty Thurine and Bill Hay and so on, really showed that there is no reason not to be starting protein at 3 grams per kilo per day on day 1. And I think we're understanding, based on gestational age, that the protein needs are going to range somewhere between 3.5 and 4.5 grams per kilo per day. What's it doing? Well, it's important for DNA and RNA synthesis and maintenance. Neurotransmitters are small proteins, right? So you need it to synthesize neurotransmitters. Growth factors, which we're going to come back to in a second here, are absolutely essential to put nutrition into motion. And I'll make the point later that you can give all the nutrients you want, but if your growth factors are not working, that nutrition will do nothing for you. And where does it go then structurally? Well, both for neurite extension, so those are axons and dendrites, and then for synapse formation, which connects those all together. So that massive change that I showed you on that cartoon is really just a bunch of axons and neurons, axons and dendrites rather, growing and then connecting themselves up. There isn't much neurogenesis at that point. You're not creating new cells in these babies who are in the NICU, but you are fostering these nerves to extend and then connect with each other. And finally, the fats are very important, and we are learning a little bit better about how much we can start and how we increase it and which ones we should use. I would say that field kind of lags behind the protein field. And you need your fats for membrane compositions, meaning even within the neurons, the ability to deliver neurotransmitters to the surface of the cell so that they can be released. And then, of course, the myelin coating on the nerves that makes them more efficient, makes the speed of information transfer faster. So it's pretty clear. I mean, when we think about macronutrients, then we think in terms of how do we judge the response to that? And that's usually your pretty standard anthropometrics. So head circumference, weight, and length is typically utilized in all of the units. And what is certainly clear is that poor neonatal growth of either the head circumference, the weight, or the length is generally associated with poorer neurodevelopment. This is where I entered the field back in '85. You know, Rich Ehrenkrantz was the person who really explored this and published it. And then Sarah Rammel has been looking more specifically at fat-free mass as a way of understanding organ growth. And we also know that macronutrient interventional strategies improve the growth, right? So recent work by Rigaud and Cook and Nick Embleton, they all show that you can move the needle. You can make kids grow better. And again, you need to be careful what you define as growth, whether it's weight gain, linear growth, head circumference growth. And that's the same story is true with micronutrients, right? That deficiencies of certain micronutrients like iron, zinc, iodine are going to negatively impact early brain development, and that supplements improve the micronutrient status. What's been difficult to prove has been to say, okay, if we improve that nutritional status, you get better growth, you got better micronutrient status, does that move the dial or move the needle on neurodevelopment? That's a lot tougher to prove. The Finns have done a nice job of looking at this. This is a paper that was published in Journal of Pediatrics in 2014, where they looked at neurocognitive abilities in young adulthood as a function of infant growth, weight gain, length, and head circumference in the neonatal period, in preterms. And they found positive effects on weight. If you had more aggressive weight gain, you had better IQ, verbal IQ, and performance IQ. Same with length, and same with head circumference. So just one of the longer term studies to demonstrate that nutrition early on does matter in terms of later outcomes. I mentioned Rich Ehrenkrantz, and a lot of his work was with the NICHD network. In this paper back in 2005, he divided up babies that were in network studies into 4 quartiles of weight gain. So this is, right now we're going to look at the relationship of weight gain in the NICU to neurodevelopment. And you can see that both on the Bayley scales of infant development, which at that time had a motor developmental index and a mental developmental index and a psychomotor developmental index, so the PDI is the motor component, that if you grew very slowly in the unit, you had lower scores on the Bayley than if you grew moderately, than if you grew better, or you grew optimally, right? And that the effects in this study happen to be just on the motor, but subsequent studies have shown both motor and mental outcomes are improved based on weight gain in the unit. I mentioned that linear growth, which is, as you all know, very hard to do properly. You know, it's like the joke about, you know, how many people does it take to do a linear measurement in a baby? At least 3, right? So you got to hold down the kid. Somebody's got the tape measure out, I highly recommend that you use length boards in your unit. But linear growth is really indexing something different than weight. And I think we've gotten to the point where we can put weight on just about anybody. But linear growth really represents the lean body mass and the protein accretion, and therefore it indexes organ growth. And among those organs, the brain is one of the primary ones. So perhaps paying more attention to linear growth would help us out. In a study that Sarah Rammel did back in 2012, she showed actually that weight Z-score at discharge or during the follow-up period really was not associated with 24-month outcome. These were kids that she studied from the NICU follow-up clinic, where they had measurements throughout the hospitalization, at discharge, at 4 months corrected age, 1 year corrected age, and 2 years corrected age. But she did find that when you looked at linear growth, so linear Z-score, controlling for the weight, right? So just looking purely at linear, that for every standard deviation of greater linear growth at discharge, or at 4 months, or at 12 months, improved the Bailey scores, the cognitive and the speech scores, at 24 months of age. And those are fairly significant effects. Remember, I told you that IUGR knocks down your IQ by about 7 points. So that's kind of in that range. She followed these kids out and has been publishing pretty steadily on this to show that linear growth, or now using a plethysmography, air displacement plethysmography machine, that fat-free mass, which correlates very closely with linear growth, is this marker of protein accretion, and that increased gains in fat-free mass, so not how much fat we put on these kids, but how much lean body mass we put on these kids, is associated with improved neurodevelopment. And it's, as I was talking about, with this kind of ripple effect from primary effects in the unit to longer term effects, that's what she sees here. So if you look at processing speed in the brain, which we do with this little electrophysiology rig, that linear growth between discharge and 4 months is associated with faster speed of processing at 4 months. If you look at linear growth in the NICU, and then ask the question, what are their motor and cognitive scores at 12 months? It has a positive impact on those. You can kind of extend that further. What about linear growth from 4 months to 4 years? Yes, you do get faster speed of processing in preschool. So the idea here is to get beyond using the word growth to simply mean weight gain. You know, on rounds, when you talk about, did the baby grow, you're usually talking about weight gain, and yet weight gain may not be the relevant thing we should be looking at. We probably should be looking more at linear growth, and certainly head circumference. The other thing that she discovered, which I think is important, because you know, those of us in the field always think, well, if you're not growing, we're not giving you enough, therefore just give more. But there's a metabolism to this whole part of this whole story, and she found that there are non-nutritional factors that affect linear growth. So for example, that linear growth suppression she documented at 2 years out from NICU discharge was driven not just by how much protein did you get and how much calorie did you get to support it, but also days on antibiotics, days on steroids, and chronic lung disease. And what do these all have in common? Well, they're all factors that either promote protein breakdown or else are pro-inflammatory. And inflammation reduces the impact, the concentration and impact of growth factors. So you could almost argue here that for some of these babies, your best nutritional solution is a non-nutritional one. Don't have line sepsis. Use antibiotics judiciously. Be careful with how much steroids you use. This brings us around to this idea of growth factors and its effect on brain growth. I had mentioned BDNF, brain-derived neurotrophic factor. But the major growth factor in the brain actually is IGF-1, just insulin-like growth factor 1, which is a growth factor for the total body as well. And IGF-1 is suppressed by sepsis and inflammation. So fundamentally, you could be giving as much nutrition as you would like, but if you don't have growth factors to put that nutrition into motion, you're not going to get your desired outcome of growth and development. This is the signaling system that many of us think it works through. There are multiple signaling systems that help determine what's down at the bottom here, which is cell size, survival, actin organization. You know, that's kind of how your structural proteins in your brain work. And you can see all the nutritional inputs into this system. This is the inside of the neuron, including nutrients and growth factors, and oxygen, and glucose, and how they all signal together, ultimately to decide how big, how complex, how well developed is your neuron. And the things that put the brakes on that are steroids that break down the protein, inflammation that hides the iron in the body away from the blood and the brain, and that suppresses the growth factors. Right? So there's an interaction between these nutritional and non-nutritional modulation of this system that ultimately is going to decide your brain size and your brain complexity. I thought this was an interesting observation that Dr. Ramel made, where she asked the question, all right, if I measure a baby, and you can see the air displacement plethysmographer up in the upper left-hand corner, if I measure these babies fat-free mass at 4 months, and I know that that's associated with speed of processing in the brain, that baby would have gone from that machine over to that electrophysiology machine that I showed you. What accounts for that? And of course, a lot of things that we don't measure apparently account for it. But here is the effect, where my arrow is, here's the effect of the caloric deficit on fat-free mass. Here's the effect of protein deficit in the NICU on the fat-free mass. And here's the effect of steroids. And you can see the steroids have just as big an effect as what you did in terms of caloric and protein intake. All right, so let's now move to the nutrients that have, you know, smaller amounts. We call them micronutrients, or the LC-PUFAs are actually part of the macronutrients, but whatever. Here again, we want to look at those that have particular effects on brain development. Iron is probably the best studied of the bunch. Iron is involved in the synthesis of myelin. It's in cytochromes that determine the energy status of the cells, how much ATP the cells can make. And obviously that's very important when you've got a highly energetic process like brain development. Iron deficiency, to the degree that we see clinically in babies, will reduce the oxygen consumption of the neurons by 50%. So you're not going to make as robust a structure dendritically, axonally, and so on, if you've only got 50% of the energy to work with. And I mentioned the monoamines, and that iron also regulates gene expression through histones. So let's take a look quickly at what determines the iron balance in the NICU for the preterm infant. And on the left, I've listed those that promote negative iron balance, and highlighted the one that I think we forget about, which is we bleed babies. And when we bleed babies to do tests on them, we are removing, for every gram of hemoglobin you take out, you're removing 3.5 milligrams of iron. Now, one could say we transfuse back, and we do, but typically, unless a baby is super sick and getting red cell transfusions because of to support blood volume or to support blood pressure, generally we phlebotomize first and then transfuse back. And if you think about the hemoglobin concentrations on your babies in the NICU, they are generally less than cord blood hemoglobins, and generally less than even acceptable levels of hemoglobin for postnates, right? Most of our babies are sitting with hemoglobins less than 10. Other things that induce negative iron balance include low endowment, so IUGR babies didn't get their full complement of iron. The AAP recommends giving iron starting at as early as 2 weeks, and certainly by 2 months. If you start iron at 2 months, you're going to be behind in terms of iron balance. The AP also recommends a dose of 2 to 4 milligrams per kilo. If you give less than that, you can expect babies to be in negative iron balance. If you use EPO, EPO increases the iron need up to 6 milligrams per kilo per day, because now you're asking the baby to use its own iron stores to make those red cells. And an important principle you need to know about iron is that iron will go to those red cells before it goes to the brain. So looking at anemia, if you have a baby who is anemic, that means that the brain is also iron deficient. Are there, excuse me, are there studies that show that there are neurodevelopmental sequelae of iron deficiency in the newborn period? Yes, there are. Starting with term infants, babies who have low iron stores at birth have poor school-age neurodevelopment, and they have poor recognition memory. And they're also not very good in interacting with their moms. They have an altered temperament where they're hesitant and withdrawn. For preterms, Sanjeev Amin has done some nice work looking at speed of processing using ABRs and showing that babies with low cord blood or low cord ferritins or low ferritin concentrations have slower conduction speeds, suggestive of a myelin deficit. Some work that our group has done in the lab has shown that there are long-term gene changes to pathways of perinatal iron deficiency that when we look in the adult hippocampus that relate to genes that are involved in autism and schizophrenia and Alzheimer's. It's just a way of, again, showing that a baby or a rat that's been iron sufficient its entire time has a very different gene expression pattern. That's what you see here on the left, compared to an animal who is also iron sufficient as an adult, but was iron deficient as a baby. And all you really need to do is look at where the blues and where the reds are, and you can see a different pattern for the formerly iron deficient compared to the iron sufficient. When you look at what pathways those code for, they're the ones that I've listed over here on the right. The other micronutrients that are important include zinc. Zinc is important for nucleic acid biochemistry. It helps regulate DNA and RNA content. And it regulates, again, growth factor expression. It's important for the release of neurotransmitters. The behavioral data on third trimester zinc deficiency shows that those fetuses have less movement, less heart rate variability, and when you test those kids postnatally, they have less preferential looking time, which is a hippocampal task to look at how well can you distinguish something novel from familiar. So this suggests that fetal zinc deficiency or zinc deficiency during that third trimester post-conceptionally, so that could include the NICU, affects the autonomic nervous system, the cerebellum, and the hippocampus. There is standard zinc dosing. I always put them on the slides, but we don't monitor zinc status. The only time we monitor zinc status is if we've ruled out every other possibility of slow growth, and this one and hyponatremia are probably the two hidden ones. So don't forget to check a zinc level, and for that matter, sodium levels in babies who are not growing. There are no, unlike in iron, there are no studies of neurodevelopmental outcomes in preterms as a function of zinc status. We just don't monitor it enough, nor would it be particularly easy to isolate its effect. Copper is the other divalent metal that's even less well known, I think, than zinc, but it's hugely important in terms of promoting iron transport, in terms of a reactive oxygen species scavenger, and in terms of supporting that neural metabolism, again, that need for the developing brain to have adequate energy. There's a group of scientists who are concerned that copper needs are increased during pregnancy and lactation, and certainly preterms and IUGRs are born with low stores. The other kids you need to be concerned about with copper are those who are given excessive zinc or iron, because these divalent metals compete for common transporters. There's a standard dose of copper for preterms that I put there, but the copper status is not easy to measure, and it's not routinely monitored in babies, and so there are no neurodevelopmental outcome studies of preterms as a function of copper status. So you're going to hear that theme in these next three nutrients, that they are ones that we know from preclinical models and from big deficit models that they can affect brain development in this time period, but where we just don't have any data on preterm infants. Everybody knows iodine is important. Iodine's only role in the brain is to make thyroid, and obviously hypothyroidism is bad for your brain. So we don't really, and here are the effects that you might see from iodine deficiency. So less dendritic arborization, less myelination, less synapses. Those fetal effects are much more profound than if you have postnatal hypothyroidism or iodine deficiency, to the point where if you've got iodine deficiency in the first 12 weeks, you'll have microcephaly and you'll have global mental deficits that are not reversible. So it's particularly important in that first trimester, but it's important really at any time. There's a standard dose for iodine that we give preterm infants, at least orally, and but iodine status, again, is not measured directly. We only can really get its effect or check its effect by looking at thyroid status. I'm sure all of you do have your babies where you check a TSH and a T4 on kids for other reasons, but iodine deficiency is something that could affect them. And again, there's no developmental outcomes studies in preterms as a function of iodine status. Something that's kind of re-emerging is folate. Now, all of you know that folate is obviously very important for neural tube closure, but it's also important for neuronal migration between 6 and 24 weeks. It's important for preterm babies who have immature enzyme systems, so you have to actually supplement babies with folate. It's pretty standard 50 micrograms per kilo, but again, the status is not typically monitored in the NICU. The third trimester folate deficiency story is evolving such that the effects look like they're primarily motor, but also some cognitive or hippocampal effects. Again, just reflecting where rapid development is taking place. And finally, the PUFAs, and I suppose I could spend an entire hour summarizing this literature, but I'm not going to. This is probably next to iron, the most studied nutrient out there in terms of brain development. And it really stems from knowing that severe essential fatty acid deficiency does really affect the brain profoundly with hypomyelination, abnormal behavior, and this has been shown in all species. Interestingly, I don't think people really understand completely which of the following effects are doing this, whether it's the myelin production, fatty acid compositions in the neurons, synaptogenesis, or just plain cell signaling. Pretty clear that preemies cannot synthesize DHA. They need it in their diets. They get it transplacentally. The work by Cami Martin is just spectacular on this stuff. And they go into rapid negative balance when they're born. We need to be giving them at least 1.5% of their fatty acids. Again, we don't have good ways of monitoring. You actually have to get the red cells and look at their membranes to really get a sense of PUFA. If you look at developmental outcome studies, they're pretty convincing, particularly that preterms benefit from LC-PUFAs in terms of mental development. But the early outcome gains, say at 18 to 22 months, haven't been particularly predictive of later function. So we need some longer term studies. It looks like some of them are starting to come out. And again, LC-PUFAs during pregnancy or during that third trimester are the ones that are having the biggest effect on later frontal lobe function. So again, these kind of delayed effects. All right, I want to leave a little bit of time for questions. So let me just summarize. Optimizing brain development in childhood, and particularly in the NICU, is an investment in society. It is those long-term effects that are the real cost to society, the missed opportunities during critical periods of regional brain development. Early nutrition, so prenatal through our time period in the NICU and in the post-discharge period, profoundly affects these primary systems that are involved in learning and memory, hippocampus, speed of processing, myelin, and emotional reward. But these areas are also the scaffolds for later developing complex circuits. And so more complex deficits can still be ascribed to nutritional effects from the newborn period. Anytime I give this talk, people say, oh, so it's all over with by 3. It's not. But as I showed you on that one slide with the dashed and dotted boxes, it just gets harder to recover the later you identify and try and redress the nutritional deficits. So early nutrient effects depend on timing, dose, and duration. and that timing is in terms of early brain regional development. Certain nutrients, which I've gone over, have a high impact on early brain development, and those effects can be global or they can be very specific, all right? And the long-term risk is mediated through this critical period idea, but also through epigenetics. I really want to emphasize that non-nutritional factors influence nutritional status through stress physiology. So reducing inflammation and reducing the use of steroids will result in better use of the nutrients you do provide to build that brain. And in the long run, when you think about the outcomes of our babies and you ask the question, what are the things we can really influence? Can we prevent intraventricular hemorrhage? Can we prevent PVL and so on? Nutrition is really something that affects the neonatal brain that we as newborn care providers can't control. So that's my pep talk for you. There are many, many people that study this, and you can see the people who work with me at Minnesota and the funding sources, but also these major collaborators. So I'm going to stop there, and I would be happy to take any questions. Thank you.
Thank you very much, Dr. Georgieff. We do have a lot of questions, and I know we only have a few minutes, so we'll try to get through as many as we can. The first one is, what would be nature's reason for making an epigenetic change during a nutrient deficiency to decrease brain development, as with brain-derived neurotrophic factors?
Yeah, that's a great question. And of course, I didn't design the system, nor did Tammy. You know, the idea, I think, behind that whole developmental origins is that that we as organisms, and the fetus being one of us, is trying to anticipate how to use the resources you're going to get. So if you're, just think about it, if you're growth restricted as a fetus, worldwide, the most common reason for that is undernutrition. It's not hypertension, it's undernutrition. And so the chances are that if you're undernourished as a fetus, you're going to be undernourished as a postnate. And so you're going to set your enzyme systems to do the following. One, to use them most efficiently, and second, to be willing to sacrifice some quality, or some quantity rather, to at least survive. So these cells, the neurons, have a very, very high metabolic rate, and they can survive by cutting that in half, but they're just not going to be as complex. So the fetus is kind of cutting its losses, is kind of my way of reading it, that if I'm malnourished now, I'm probably going to remain malnourished, and I'm going to set my systems that way. That's the best I can describe it, and that applies to the cardiovascular system as well.
All right. When talking about macronutrients, and more specifically protein, does this have to be intact protein, or would you get the same impact when using amino acids and not bioactive protein?
Yeah, that's an excellent question too. And Bill Hurd spent a lot of his career trying to ask the question, are there certain amino acids that are rate limiting? There was a time actually when the first TPN compounds came out for preemies. They targeted, you know, they compound these things by putting amino acids together, right, in the solution for the baby to then have the baby who gets the infusion have the amino acid spectrum concentrations of all the amino acids that a term breastfed baby has. Now, we all know at this point that probably was a mistake, because, you know, the term breastfed baby makes do with 1.1 grams per kilo per, or 1.5 grams per kilo per day of protein, whereas preemies have a much higher need. Determining what that perfect blend is, I'm not sure we're there yet. Dr. Hurd was very concerned that certain amino acids were being shortchanged. So I think that's still a work in progress in terms of not just delivery, IV, enterally, but then what gets reflected out in the serum. That companies are still working on that.
Okay. Given the negative effects of inflammation, how important are antioxidants?
Are antioxidants?
Antioxidants, sorry.
Yeah, that's a good question. Antioxidants have been a very difficult area of research to really come up with proofs. Oxidant stress is a very real thing. It damages DNA, it damages mitochondria, compromises, therefore, the ability of the mitochondria to make a cell, like a neuron, do the right thing. A lot of oxidant stress that you see in cell cultures and in tissue in preclinical studies have been difficult to reproduce in humans, or to detect in humans, unless there's massive injury like hypoxic ischemic disease. And so it makes it really, really hard to know. And I might add that when you have a deficit in one antioxidant, let's say vitamin E or vitamin A, it can often be compensated for by the host of other antioxidants that are out there. So there's no really good one-to-one correlation of, gee, you didn't have this and therefore you had oxidative damage and you didn't develop well. It's a very complex field. So I would say at this point, maintaining your antioxidant defenses through those nutrients that are natural antioxidants is important. It's important to have them in the right area. And an example of how we utilize that at the bedside is we don't typically start iron, which is a strong pro-oxidant, until about 2 weeks of age, because that's when the vitamin C system, a very strong antioxidant system, has finally matured.
Great. Well, I know we're at the end of our time, Dr. Georgieff. So unless you have a few minutes, we do have more questions, but I want to be cognizant.
I can stick around for a while.
Okay. So the next one is
the questions, but I can stick around.
Okay. How do you resolve the conundrum of detrimental effects caused by inflammation versus those caused by anti-inflammatory medication like steroids?
Yeah, that's a great question. So that certainly has a lot to do with in the pulmonary field, right? And we have asked our group has asked that question, and I'm not sure we know where that balance is. So on the one hand, steroids will reduce inflammation and in the lungs and will make the baby have less chronic lung disease. You can utilize your nutrients better. On the other hand, steroids that get to the brain, particularly dexamethasone, all the steroids, have profound effects on our anti-growth effect on synaptic genesis and nerve differentiation. I think the practical answer to that question is use them sparingly and don't use them for long periods of time. The DART protocol of 3 to 5 days seems to be as protective as it can be. There's no question that a baby with less BPD grows better, has better head growth, has better developmental outcome. If you need to tweak it a bit with steroids at the risk of perhaps affecting the brain growth, yeah, that's where that kind of tipping point is, and I'm not sure that any of us have an exact answer for that. But I think most of us feel that the DART protocol is about as safe as it can be and is effective in terms of reducing the energy demands of BPD, which is taking energy away from the brain.
Okay. Very interesting regarding the non-nutrition factors that affect linear growth in terms of promoting a healthy microbiome, especially with antibiotic stewardship. What is the role for probiotics?
Yeah, that's a great question. So actually, when I saw the antibiotics association in Dr. Rammel's study, I thought, well, yeah, so, we don't just, we do, I guess, just give antibiotics. But I was assuming that we were giving antibiotics because of infection, and it was the inflammation that was reducing the linear growth. And I was at pediatric academic societies, and a wise person came up to me and said, how do you know it's not the microbiome? I don't know it's not the microbiome. It may well be the microbiome. So again, antibiotic stewardship may be just as important as antibiotic usage, where you have a true infection, knock down that inflammation, get the kid back into an anabolic, I can grow now kind of situation, versus giving antibiotics for every time the kid blinks at you abnormally, and you put them on, you change the microbiome, and that signaling, we know the signaling from the microbiome, at least in preclinical models, affects brain-derived neurotrophic factor and development. So yeah, absolutely good point by the person who asked the question.
Okay. The next one says, nice talk, thanks. Pepanic study, which is Fives et al., in children/infants suggests that nutrient supply in excess of metabolic capacity may be harmful. In real life clinical practice, would you A, still start at 2 to 3 grams per kilo amino acids and increase daily to 3.5? And B, would you reduce amino acids intake during critical illness like NEC?
So yeah, that's a good question. I am fully confident that, when you clip the placenta, clip the cord, you're disconnecting the baby from a significant amount of protein, and you go into negative protein balance very quickly. And so Scott Denny's work on this and Brendan Poindexter's work on this is very clear. So and then the work from the Colorado group that shows that amino acids are perfectly safe starting at 3 per kilo and moving to your target is the appropriate way to do it. Illness does funny things to protein. In the adult critical care literature, and just a little, you see it a little bit in the preemies. There's this thing called autocatabolism when you're really profoundly infected with necrotizing enterocolitis or with bloodborne infections, so that your protein needs actually go up at that time. So unless you're in profound renal failure or hepatic renal failure, going up on amino acids may be appropriate actually for when you are septic. That's still very that's a difficult area. Tom Jackstick at I think he's at Boston Children's has done some of that work. The overall point though, that illness changes your nutrient needs and changes how those nutrients are handled by the body. You shift from anabolism, diverting that all to growth, to breaking things down in order to have gluconeogenesis is really profound. So knocking down the illness factor should then get you that back to the anabolic stage.
Okay. We're 6 minutes over. You still want to keep going, or do you
maybe another 4 minutes is fine.
Okay. All right. Great. The next question is earlier initiation of iron supplement appropriate? For example, starting before 2 weeks of age for a late preterm infant?
I would say not. There's not a lot of information on the maturity of the antioxidant systems, at least that I'm aware of, that says a preemie is any different than a term baby. To be honest, there's no reason to start right away. You could probably start at 2 weeks. I would point out that the iron needs of that late preterm are double that of the term baby. And especially if the babies are breastfed, you absolutely want to have them on at least 1 per kilo, if not 2 per kilo of iron. But I'm not fully confident that their antioxidant systems are mature quite yet. I would probably wait the 2 weeks.
Okay.
They're not growing fast enough to really worry about it, right? The biggest pressure on your iron system is how rapidly your blood volume is expanding, which means how rapidly are you growing. There's not that much growth in the first 2 weeks.
Okay. Can you discuss issues with high-dose enteral iron supplementation and zinc deficiency due to poor absorption?
Yeah, so they compete with each other, and when you give high doses of iron, you will reduce zinc absorption, and so we need to be aware of that, particularly as we get into some of these really high doses of iron with erythropoietin. That's a good point.
Okay. What dose of LC-PUFA do you recommend is shown in studies during pregnancy or third trimester for optimal neurodevelopmental outcomes?
Yeah, you shouldn't ask me questions about doses, because as anybody from my team will tell you, that's the first thing that goes that you don't remember, and then you're dangerous. I think I had on the slide that it should be 1.5% of your total fat intake.
Okay. What amount of zinc and iron?
I should say I don't know about moms. I have no idea. I don't treat moms, but for the babies, it's 1.5%.
Gotcha. What amount of zinc and iron supplementation is considered excessive and could impact copper?
Certainly doses when you get beyond 6 per kilo of iron, we start to worry about that. And that's actually why some people use split doses. Some people use every other day dosing to try and at least balance things out a bit. I'm not sure I know the exact number on zinc. The problem is usually with iron, actually.
Okay. And the last question we have, are you supplementing all your babies and or mothers with DHA? I don't believe preterm formulas or FEBM contains that high of a percentage of DHA.
So again, I don't treat the moms. I am aware that our maternal fetal people are putting moms on vitamins with DHA. The work by Susan Carlson shows that the fetal period is really the important period. And if you want DHA to really affect neurodevelopment, The long-term outcome studies are predominantly with maternal supplementation. She doesn't study preemies necessarily, but that seems to be a critical time period. The addition of DHA to preterm formulas was an interesting event because that came from the fact that it was generally recognized as safe, meaning it's in our food chain because it's in breast milk, and therefore could be added to term formula. And then suddenly it's in the preterm formulas just as kind of a sideways move. I don't think it was ever approved in an official, in a way that FDA approves drugs. The generally recognized as safe is an approach that says FDA reviews the information and then says, let us know if there are any problems, as opposed to the companies having to prove that there is a positive health benefit. So I think it just kind of moved over into it. But I think all of the formulas now have that in them. And should.
Great.
And should. The babies won't synthesize it, so that should be in there.
Great. Well, I want to thank you so much, Dr. Georgieff, for your time and your insights today. As we talked before the webinar, every time I hear you talk, I learn something new. So, and we want to wish everybody a safe and healthy holiday season, and come back and see us in January for Dr. Sarah Taylor's talk. So thanks again.
It's a good one.
All right, great. Thank you so much.
All right, bye, thanks.
Bye-bye.